Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have a couple of cases here which both involves me peeling away dead skin, dead keratin. And this is patient 1, and as you can see the ear canal is not occluded, but they've got this skin around the perimeter of the ear canal, and the reason for removing it is twofold. The patient suffers from extreme psoriasis, so extreme itchiness of the ear as a result of this dry skin, and they need it to be constantly debrided, so removed, to relieve them of their itchiness. But also this dead skin is causing, more so in their left ear, their hearing aids to feedback. So hearing aids, they capture environmental sounds via the microphone on the exterior surface. That sound is then digitized and processed and then amplified into the ear. And if that amplified sound escapes out of the ear and re-enters the hearing aid microphone, it means that the hearing aid is re-amplifying a sound that it's already amplified. And that cycle continues, so that the hearing aid then re-amplifies it into the ear, and that sound once more escapes and it re-enters the microphone. We get what we call a feedback loop. When you experience a feedback loop, you can hear audible whistling and chirping of the hearing aid. It's similar to when you hear feedback at, for example, karaoke, when someone, the microphone gets too close to the speaker, for example, and you get a feedback loop there. So whenever we remove the dead skin, the hearing aids instantly stop feedbacking, and of course they don't experience this itchiness. So we've just got a bit of dead skin here, just at the entrance. You may have seen we removed a thick layer of skin from almost the entire length of the ear canal. The eardrum looks nice and healthy. You can see just by the appearance of the floor of the ear canal how dry the patient is. Now, the patient is in their 90s, and unfortunately, as we age, we do generally experience more dry skin, not only in the ear but other parts of the body, and that's because the skin cells are less able to retain natural moisture. So the internal moisture from the skin cells, they escape and they evaporate, which causes the skin to become a lot drier. And when you've got dry skin, particularly in the ear, it crusts, it can't naturally migrate out of the ear because of the added friction, so it collects and dies into the ear, which can then lead to itchiness and irritation. And case 2, it's really interesting, so do stay tuned for that. It's a similar looking case on first appearance. You look into the ear canal, which is not occluded, but they've got this thick layer of skin. And upon removing that skin layer, we find an underlying pathology. So do stay tuned for that, and I'll explain a bit more once we're presenting case 2. So this is the same patient, but this is their left ear. Again, you can see this thick layer of skin. Now, this ear in particular was causing the hearing aid to whistle. It was audible when the patient is waiting in our reception waiting area. Actually, I could hear it. And that's because the skin was more semi-occluding. You can categorize wax and dead skin in terms of how much they occlude the ear canal. So if you've got an ear canal that's completely blocked, where there's no route for sound or air to travel through the ear canal to the eardrum, we can call that fully occluding. If the eardrum's half visible and the ear canal's only half blocked, we call that semi-occluding. Then you get partial occluding, where a portion of the ear canal's blocked, but you can see the majority of the eardrum. And then, like the right ear, that was non-occluding dead skin, where there is some debris or dead skin, earwax in the ear, but it's not blocking the ear canal and the eardrum's visible. So just mopping up the entrance of this left ear. This patient used to suffer from really bad fungal infections years ago, and the skin used to, you could see spores developing on it, but fortunately the patient no longer experiences that. In part, they were getting water in the ear previously, and that may have been a contributing factor for the patient developing a fungal ear infection. If your ear's dark and you've got dead skin already and it's warm and moist, it's a perfect incubating environment for harmful bacteria and fungi. So we advise the patient to avoid water, and fortunately they still get their dead skin, but it's it's not as problematic now. This is patient 2, so you can see at the entrance, this is more on the anterior inferior canal wall, which means more on the front part of the ear canal near the bottom, and it's the bony part of the ear canal we're dealing with. Now, it's got this very thick layer of skin, and underneath this, it would appear that the patient's suffering from benign osteitis. Now, pathologies in the ear canal, they're generally 4, maybe 5 types of pathologies that we need to be aware of. The first one is keratosis obturans, and that's an accumulation of a dead skin plug that occludes the whole ear canal, and it widens and expands, and it actually can begin to then start widening and distorting the shape of the ear canal. So that's a keratosis obturans. You don't get any pus or mucus like this. So we know this is not keratosis obturans. Then you can get malignant or necrotizing otitis externa. That's a very serious condition. It's very rare, but it's when the temporal bone gets infected, and this bone infection can then spread to the skull base, so it leads the brain. It can lead to a brain abscess, so it's potentially fatal. It's normally caused by gram-negative bacteria, and clinical symptoms of that is generally granulation tissue. So you get inflammation tissue at the floor of the ear canal. It's very moist, and the patient reports with nocturnal otalgia, so pain at night in particular. And it is a rare condition to begin with, but those patients who do experience necrotizing, or also known as malignant otitis externa, they're more likelier to be diabetic or immunocompromised or quite elderly, so their body's less able to fight the infection, hence why it can spread. So there's no granulation tissue here, so this is not malignant or necrotizing otitis externa. So there's 2 conditions that this could be. The first one could be a canal cholesteatoma, and the second is benign osteitis. It's difficult sometimes to separate the 2, but a canal cholesteatoma is again normally characterized by an occlusion of the ear on first appearance. So when we examine the ear, it's completely occluded, and then you get necrosis of the bone, the temporal bones, the bony part of the ear canal, the inner 2/3. That bone, it starts to die. Generally, it dies in response to dead skin getting infected and collecting in a crater caused into the ear canal. Whereas a benign osteitis it's not normally the ear canal's blocked. So again, this ear canal wasn't actually blocked. And also it's to do more with poor vascularization, so poor blood supply to the bone, supplying the bone. So the bone's starved of nutrients, oxygen it needs to stay healthy, and that leads to a destruction, a death of the bone, the decay of the bone. And this bone can then start separating from the main bony part of the ear canal, and quite often you can see small fragments of bone that you're removing from the ear canal. So it's either a canal cholesteatoma or benign osteitis. We have made onwards referral. My gut feeling is that it is just benign osteitis in this case. It's not a canal cholesteatoma, which is very rare again. So as you can see, we're just trying to clear that away. Treatment for this, sometimes surgery is required to help to revascularize this part of the ear canal and to patch up that crater. Once you've got this crater, it's going to lead to a constant buildup of dead skin getting into that crater. So as the ear canal dies and the skin that lines the ear canal dies and it sheds itself, it migrates sideways. And when you've got an opening, a crater, a pothole like this in the ear canal, skin can start falling into that, and that skin can then get infected and then potentially lead to a canal cholesteatoma. So this patient's very likely going to have their ears cleaned on a regular basis now. They are a hearing aid wearer. I've just advised them not to wear the hearing aid, and just until they're seeing their ENT so they can get some further treatment. You can see there's an ulceration of the skin, so that skin that lines the bony part of the ear canal, it's breached. The bone is exposed, and it's kind of separating and dying and decaying, and the adjacent skin is very inflamed. So if I hedge my bets, I think it is benign osteitis, which is less serious than a canal cholesteatoma, but nonetheless, it still needs to be treated accordingly. And just using a Jobson horn just to separate some dead skin from the posterior canal wall. Just moving that away. So with a canal cholesteatoma, again, it's a localized pathology within the ear canal, unlike a keratosis obturans, which the skin plug affects the bone all the way around. It diffusely affects the canal portion, the bony part of the ear canal, all around the perimeter. With a canal cholesteatoma or benign osteitis, it's more localized. And it's with a benign osteitis, it's normally the floor of the ear canal. And with a canal cholesteatoma, it can be anterior, so it can be to the front, but more often it's more posteriorly, because the skin posteriorly to the ear, the back part of the ear canal near the floor, it has a slower rate of migration, so that skin, it can't migrate out of the ear as quickly, so it can then build up and get infected. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.